Okay, Dr. Abdul
I'm
Rahman.
Dr.
Yeah.
I'm Dr. Azhar from Bangladesh.
Yes. And great to have all the nice and expert panelists for this our Meet the Master and this webcast which has been going on for last 2+ years now, 3 years actually. And we are happy from
The
Mount Sinai
paper, bring
Cath
it
Lab to
here.
relay myself, Dr. Keeney, and then we had two fellows on my right side, Kushal Chowdhury and Sabina Kumar. And we actually had total 8-9 fellows in the interventional, doing 4,000 interventions. And our staff being Eldina and Will, and CVT Asif and Peter, and imaging Kiski. So with the same crew, we just start our case presentation. It may take a little time because it's one of the very complex case which we are showing today. Show the angiogram. So this is our goal today is the IVUS guided plaque modification using RotaCut approach, and that will be the goal today. And let's see what happened to the slides. They disappeared. They may come back. Good. And these are, now I don't know who in the expert panelists which were initially circulated to me, Dr. Rajiv, Barua, Vivek, Saravan, and Ripen Gupta and Sumantha Padi. How many of or all these panelists are there or we are added on? We'll see one by one, and of course supported by Boston Scientific. Disclosure as nothing. This is the case number, live case number 21. 82-year-old female presented with new onset angina, positive stress test, has multiple risk factors, controlled, and no cardiac history before. And echo showed normal ejection fraction. All the creatinine is 1.8. She also has multiple myeloma. GFR is 2930. Rest are good medical therapy, many of them for multiple myeloma. And she had a cath and on June 30th because of those positive stress tests and angina, and has a 3 vessel. Of the 3, RCA just was AV continuation, but critical lesions were in the LAD diagonal and OM. OM was taken care by the Rota and Stent, and now we are here for the LAD diagonal intervention, which will show that is our plan. And let's go to the angio. Yeah,
So
look at the
this is
calcium.
no. So this was the circ PCI. Looks okay, and this is where we are. Dry cine, you can actually see the tram track calcium of the LAD all the way. The entire vessel is calcified, including the diagonal.
Yeah.
And this is the true lesion. So mid LAD, I would say looks subtotal, but subtotal to total and significant disease of the diagonal bifurcation, and also the the disease goes all the way down to the apical LAD. Not
Yeah.
apical, I mean mid to distal.
Mid to distal, and I mean by definition it's a 0-1-1. And question comes is that what you do first in this case, now knowing that there is a diagonal disease, and but I think we can take the opinion, but I think we have to take care of the LAD first with a very calcific subtotal vessel that we have to engage and wire first, and then of course then use the atherectomy. That is the plan. So Anu, tell us where we are now, and while we are taking the opinion from our moderator and the panelists there.
So of course we decided we'll go the LAD. Couple of things in this patient. So her creatinine, if you see, was 1.9, today is 2.2.
Oh, 2.2.
Yeah, and EGFR is about 26, 82-year-old lady. So the question, I know we have a plan was to take care of both LAD and diagonal. Okay, that do we just take care of the LAD and leave the diagonal alone? That's one. Now, if you are going to do the both of them, do we need atherectomy of both vessels? Reason I'm saying is this is going to be highly complex intervention, and with that kind of EGFR, with that elderly patient, that should we just change our strategy? That's so
Okay. Let's
if you are
ask
doing
the
LAD,
let's ask the opinion from our the panelists that what do we suggest? Any different opinion on that?
Samin,
Yeah.
Yes, was said that we addressed the circ disease earlier.
Yeah.
Uh, so, was it thought that that was a culprit lesion or this was staged for the live? How was the
I mean,
thing?
yeah,
And
very good point, because this patient was not a unstable. It was a positive stress test, and it was both apical and infralateral moderate to severe ischemia with a normal ejection fraction. So it kind of both, the OM also was, I would say, 90%. But if you think about the LED, definitely LED diagonal is more critical and much tighter, particularly the LED, which is subtotal. Yeah.
from what Dr. Kinney is telling, it's becoming like something like an ultra low contrast PCA now, given the fact that her creatinine has jumped. So maybe keeping it simple would be better, in my belief. So taking rota into that little bit tortuous diagonal will be a challenge.
Yep.
In doing tor zero contrast with the rota again would be a challenge. I would say maybe address the LAD. Diagonal Austin doesn't look. Of course, we do IVUS, we find plaques everywhere. So we need to use our discretion to see whether we can come out without using much contrast.
Okay. All right. So let's say any other opinion, and we'll work on it, and tell us now what you want to do now.
So we use a fielder fine cross to cross a lesion. So this is, you see that fine fielder, you go all the way up to the lesion, advance it. Still I'm having issues. It keeps going to, there's a small septal before the LAD lesion. You see that? So it keeps going to that septal. And then we are, even if we cross, okay, so when something like that happens, you advance the fine cross, you get more support. So even if we cross, now there is a septal after that lesion, so we keep going into the septal. So we need, even this, if you want to just use this fielder wire, we have to remove it and change the curve to some extent, so it will get into the LED, that's one. Or use slightly a wire with a more tip load.
Yeah. And what is the plan now? So I
So
think that's
I'm changing to Miracle 3.
Okay.
So the different wires, if somebody is saying, let's you try other wires, they want to use Fielder XT, doable. Some people will tell, I would want to use Pilot, which has a lower tip load, but it's a hydrophilic coating. The one good thing about, so many times hydrophilic coating tip, they keep going to the side branches, because even the fielder kept going into the diag more than getting into the LAD. So hydrophilic tip coating goes into smaller vessels. Hydrophobic means no coating. That's the kind of tip that you need. That's why we picked Miracle 3 now. So let's try with the Miracle.
Yeah, so Miracle 3 now. Okay, so need little stiffness at the wire tip. With the Fielder XTA, Fielder FC, we are not very, I would say that pro about it, because we are not seeing the much use. So once we fielder, regular fielder does not go, we just go with the little more stiffer wire, whether it's a Miracle or more important, I go with the Gaia 2 in this case. But
see, Gaia 2, you have to make extra tip, you have to get into the LED.
no, but creatinine became 2.0 when? It was 1.9 earlier. It's 1.9 still. Okay, good. So that's okay. So basically did not jump after the last angiogram, which was about three and a half weeks ago. And patient is, as I said, one of the big issue in this patient is the multiple myeloma. And that will determine the lower contrast use is very important. Last time also told contrast use was 42 ml cc's only. And so here, I hope we'll come out to be in a double digit contrast only. So patient's creatinine used to be 1.8 for a while, and now it was 1.9 today. So that's good. Continue hydration. I know that a lot of people have gone against mucomist because of the trial. We also stopped doing it. But whether it works or not, we may take the opinion of our poll that how many people use the mucomist. I know that in India we still use quite a bit of the N-acetyl cysteine.
In guidelines, it is 3.
Guideline just said 3 were no benefit.
Yes.
3 had 2 points. One, it caused harm. Secondly, no benefit. So mucomist is in the category of 3, no benefit. Class 3, no benefit, but no harm. But there are many of the class 3 are harmful. So mucomist does not come into that category.
Get the laser ready.
Dr. Kinney, are
Yeah.
we able to get fine cross across?
Yeah, right there.
No,
We're
no.
trying
We
to
are
move
working
it.
there.
Yeah. I think we'll be able to get it right there. It's going there now.
Okay, now we got it.
Because if it does not go, then we have the
Are you
laser
able
ready.
to see
Yeah.
my hand movements on the ceiling camera? Yeah. So
Yeah,
you
yeah,
see
we are
that I
seeing
was,
you
yeah.
talking.
Yeah.
Yes. Just fine backward forward. So you see here with this one I'm going backward forward, and with my left two fingers, which is a thumb and my index finger, I'm just advancing forward. It's the same thing even if you're using a Corsair. If you can watch that, that's the fine movements. Okay, so we went, now I went all the way to the apex because it's all diffusely diseased. So we will not have an issue to get the rotawire down. So we will get the floppy.
The rota floppy. Yeah, good. This is out here. Rota. And question is 1.25 or 1.5 bar?
I think 1 fiber.
1.5. Yep.
Okay.
Yeah, if you would not have crossed, then we go with a 1.25, means if the your over the wire system, otherwise I think 1.5, so at least get some benefit of it, yes. Prepare 1.5.
নিয়ে এসেছে দেখে তারপরে সেটা তোমাকে দিবে ওরা সমস্ত দিয়ে থেকে পয়সা থেকে তো
Now somebody else on the phone with their is on.
On the Zoom, there's some,
বলতে পারে দিয়েছে
this happens every time.
One
Somebody else is talking.
15. No.
Who is managing this Zoom meeting?
Yeah. Good. Okay, so this is a rota floppy. Our
No need. No, yeah.
we don't need the laser now.
So what happened is when I was having trouble in crossing the lesion with the fine cross, I already called for laser because, the laser requires some time to warm it up.
3 or 15
If
balloon.
the fine cross had not crossed, then there is two ways to handle this. One would be that you take the fine cross as far as you can and then try to free wire with the rota wire, which you do in certain situation. Other thing is, people will say that take a small balloon, try to go there, dilate, and then do rota, which we don't do at all. But I know during the live cases that suggestion do happen. What we do is, if we are not able to do free rota wire, once the wire is across and the fine cross or any of these catheters do not cross, we would use laser. And after that, that you have created some channel with the laser, we can do rotational atherectomy.
So any further opinion, advice from our group there? We have 1.5 bar ready now. Rota drive, floppy, and the same.
Some disease in the distality. So
Oh,
you
yeah.
need to ablate that also, or you want to just play safe by doing only the middle lady?
Well, I mean, that's a very good point, and that's why we're thinking that should we just put a short, because longer we do, more dye and more optimization will require. Now see this now, this view. I think this is the one we should decide. I think we just go about that septal. I mean, there is a further disease down. I think we can go a little further up to like 2 o'clock position and put one long stent, 3032 synergy.
Dr. Sharma,
Yeah.
there's a question in the chat as to when you would use an extra support wire.
Yeah, so very good point. The extra support wire, by and large, we use the floppy rota wire drive and extra support only in situation with ISR or very distal lesion or sometimes ostial, where you have to release the, take the guide away. So that we use in about 10-15%. The problem is because regular places, it will cause a tremendous wire bias. So it's not a one which we
Full back
usually
LAD.
use, except 10-15%.
Full back.
So, and you see that the Rota Pro comes ready with the 150,000 RPM. You don't have to touch it. I work very hard to come up with that those numbers and so. No, it's not pulling it. 1 second. The guide is. Remember, you have to have. The key is you have to have relationship with the guide and the wire. Guide does not come out. Wire does not come out. So that's a relationship. Good.
I'm pulling the wire back because distally the wire was okay. So we are in the left main, and you see, I mean, angiographically disease free proximal LAD, so we can go all the way there. So we'll do our 3 steps to remove. Now you remove for to get the rota bar all the way there. Now we have created some tension within the system. So essentially you take your knob, you move your knob, remove the knob backward forward. So any tension between the Teflon sheet and the bar is gone. Now we are at the Y connector. Now look at the flow row. Go backward forward, you see that nice movement. So any tension between the burr and the wire is gone. So essentially there are 3, right? So it is the wire, rota wire, the burr, and the Teflon sheet. So you have to make sure all these 3 are freely moving, so there is no stored tension. So when we are starting burring, so the last one is you use your dyna which is on, and you do a tap. So even when you do that, you see no movement. So even if there is a movement, that movement will happen with 70,000 RPM. So the risk of burr, moving forward with high speed, causing dissection, very rarely perforation should not happen. So these 3 steps are very important. And now we are ready to burr. Now we come off the dyna, we are ready to burr. And the burring is the same, slow pecking motion, and not more than 20 seconds.
150, 5 seconds, 150, 150, 10 seconds, 50,
Okay.
43,
And keep seeing the hemodynamics as well as the drop in RPM.
40,
Yeah,
50, 1 second,
you can wait.
21,
Yeah.
So Asif just said 20 seconds, 21 seconds. When we hit more than 20, their voice becomes louder,
Yeah.
telling us to stop.
So we stop at 20 seconds, also maintain the systolic pressure above 100. And then the drop in RPM, as you see that rota console will tell you the open triangle, yellow triangle, open will be your 5,000. If 10,000, it will be a full triangle. And of course, it's more than that will be the red. And so once it is done, just do a 1 or 2 polishing. It doesn't help much, although we move the wire position to make it a little more directional time to time. So because burr, a lot of people say that go maybe slower speed, which will make it a more directional rotational atherectomy, just like orbital, that going at 100,000 RPM, which has been touted basically by Japanese and so. But we not have adopted that, and we'll just go maybe move the wire position. So clearly wire position will bring your burr into a slightly different direction while the rota is being done. Okay, we're done.
No, I think we decided we are just going to do
Yeah.
short segment.
Yeah.
Now, if you really have to go all the way to the mid to distal LAD, 1.5 may be a larger burr. You may have to be 1.25.
No, but we are okay now. We are done.
Okay, then we're coming
Okay.
out. Ready.
So we are coming out now. Get the run through wire from there.
So everybody decided we are just doing the main vessel.
No, I think we'll do the diagonal also. As long as we are not giving any dye.
Now again we need fine cross to get into that diagonal.
No, diagonal will go directly.
No.
Yeah, so what will happen is, a lot of people say that what to do now. So key is, we'll do very simple. We are going to put a parallel wire into the LAD and then dilate with a balloon. Looks good, then we pull back the rota wire and try to dilate into the diagonal. If it goes easy, then we go further, otherwise we can still use a 1.5 burr in the diagonal. Yeah, let's go into the LAD first.
If I would not dilate the LAD. If you think we are going to do the diagonal, we do the diagonal right now. Because if we have a dissection in the LAD,
No, will not have dissection at the low pressure. It will just open it up. And all the diagonal may be a 1.25 bar anyway. But that's a separate story. But let's put the wire, let's dilate with the balloon. So I just want to make sure that the lesion opens up. Otherwise, you have to combine either bigger bar, which I would not prefer, or combining with a cutting balloon. That is one approach. We can combine with a cutting balloon, or we use a IVL. But usually RotaCut approach in this kind of case, you have done a good plaque modification, and we'll trying to see it with the IVUS later, that what has been created. But I don't think we should do any IVUS here at this time. But as long as the whole question of not doing the diagonal is also good size, is basically based on the contrast used. If you are not using any contrast, then it's okay. Go. So diagonal is still plus minus. Yeah. Yeah. There was some question, sorry. The wire is preferentially going into the diagonal.
Are you sure it is 15 frames? Looks like 7.5 frames to me. Huh?
The 15.
Yeah, like I said earlier also, because it's a...
Yeah, calcific lesions definitely have a little problem with the non-hydrophilic wires. Hydrophilic wire may still go. So here, this is our same run through. That's our workhorse wire for us.
I think I would just stick to LAD.
I mean, patient 80 years plus. So if you want to keep it that way, it's not wrong also.
With multiple...
Right, everybody agrees? I think we should take a little vote by our audience and panelists that would you go with a diagonal or not? Because diagonal, we can put a stent after the diagonal in the LAD because lesion is like 0, 1, 1.
So you start working on diagonal, obviously you end up in IVUS guided PCI, which I feel that it becomes a bifurcation stenting.
Yeah, no, it will be, yeah. So keep going. So right now we are doing the LAD. So question always is that do we do diagonal or we just come out with the LAD on this particular case, knowing that the diagonal is not subtotal. LAD was total, subtotal. And so this is a 3 of 15 balloon, and then we have a 3 of cutting balloon also will have RotaCut approach. So let's just, you need to pull back a little bit. Now IVUS is ready. Yes. So this is the case now. It's about time to do IVUS.
Okay, done.
That doing that additional cut. So what is the final verdict by our panelists and the audience? Diagonal plus or minus? Or want to do it based on the IVUS of the LAD?
I was on the LAD.
Okay.
Because if you can retain the same flow to diagonal, you can leave it. But if there is any compromise, I think diagonal needs to be done.
Okay.
Because it's a large territory.
You need a cine for that.
Yeah, we'll do. But just do the IVUS first.
Don't touch
Want to make sure that LAD has we did the rota, we did the balloon, and we are going to do a cutting balloon of the LAD to optimize. And then the plus diagonal ostium, how it looks. Do all the imaging gurus tell us what we need to do. Rota wire you definitely can pull back here into the guide now. We don't need to keep the rota wire
Richard,
there.
we do IVUS.
It has done its job as the modified cutting balloon.
Come closer.
Yep, good.
Yeah,
Okay,
can you
tell
show
us, we'll be probably in the plaque.
You
Yeah,
want to
can you
take
show the
rota
IVUS on the screen?
No, leave it.
Okay, IVUS, please.
Yeah, okay, I start pullback. Like a severe disease, like around 360 calcium. It's coming. The branch here, it's a proximal LAD. Proximal LAD also has a lot of calcium, but lumen is open.
Okay,
Then come to the left main. Yeah, stop it.
take it out. All right. Analyze and tell us.
Yeah, we'll check again. So this is a, like a mid to distal LAD.
So there is a disease in there, in the mid, although not that calcified, correct?
Yep. So okay, I see. So this is the big branch. I think this is our diag. So after that, so this was the CTO lesion, but this is after loader in the balloon. I see some big calcium fracture. So after the diag, our
Nice plaque
tightest
fractures, yeah.
yeah, I think it's a good plaque modification. But the issue is diffuse plaque after that. So yeah, all calcified, and some part I see
to
that
focus on Kiski.
some part I see the EL to EL, and the vessel size distal is like 3.3 vessel. But the issue is there's no good landing zone. Yeah, even the start of the pullback is like a lot of plaque, but the vessel size is like more than 3.0. But our tightest part will like prepped after the rotor and the
And
balloon.
how is the ostium of the diagonal? Looks okay, right?
Because from this pullback, yeah, it looks like open. If you want more detail, we can do the pullback from the diag. But from this cross section, looks like ostial diag looks open,
Okay.
and the proximal to the diag is also some calcium, but lumen is okay. So
But the lumen after the diagonal, how does it look? Because we did some cut,
yeah, so
and should
is
we cut more? I mean, do a cutting balloon here now?
Based on the IVUS, you don't need it.
yeah, because the
Just-
3 o'clock
yeah.
we see some huge calcium fracture. I think this is a good plaque modification by rotor in the
By
balloon.
rota and balloon, you have achieved a good plaque modification.
I think so.
But no, but what is the circular lumen you just got? Yeah, what is this?
Yeah, this is just after our CDO lesion. But the surface still has some fracture. Not huge, but I think some fracture here also.
This is after or before the diagonal?
This is
After
distal. You have to say use the word distal.
Yeah, distal.
Yeah.
Distal.
This is distal to the diagonal. It could be also I went further down to before the balloon. I mean distal to the balloon.
Yep.
This area may be the tip of the balloon.
Yeah.
Remember, we decided we are just going to take care of the LAD at the level.
No, but
of
you cannot leave a very tight lesion in the LAD and suboptimal diagonal results. I mean, you have to open the LAD. What is the lumen there, where there was a circular?
Oh, so this is the area still like 2.5 or something.
2.5.
Yeah.
No, you have to take care of that. Remember, if you decide that we are going to take care of the LED only, but then you have to have a LED nicely open. You cannot have a significant plaque. I know a lot of disease distally after the mid at 3 o'clock, but that area you have to contain. So this is reasonable. We have done little rota there. Maybe do a cutting balloon with a 2.75
So then if you are,
Yeah.
no, not 275.
or
You have to
2.5.
go 2.5.
2.5.
In
2.5
that-
cutting balloon, yeah.
In that situation, then you have to go all the way, the entire LED.
No.
disease.
Until 3 o'clock only. Leave everything else alone. Just till 3 o'clock. Yeah. Okay.
So if you're
Yeah.
going ahead with cutting, will you keep a protection wire in the diagonal or just go ahead and cut?
No,
Take
we
the rotor
decided
out.
we are not going to
Yeah.
go anywhere near the diagonal.
And then our goal will be that we are going to go distal to the diagonal. So that is what the plan is at present. Whether we will keep that plan till the end need to be seen. But one thing for sure, that area in the mid LED where we may have done little rota, but definitely did not do the balloon, has very tight lesions. See that? With a lumen of 2.6, 2.7. So that need to be taken care.
Okay, that's a 2.5 balloon.
Yeah. And stent could be 2.75, 32. And then proximally we can dilate with a 3.25. Because proximal vessel is about 3.25 to 3.5.
No, I think, he was giving a EL. We don't want EL
No,
with the
3O.
lumen. I think we can do 3O balloon.
3O balloon, yeah. Good.
So this is a 2.5, right?
Yeah. And we do a few
Already.
dilatation and then we'll take a picture. We are not taking any picture, or we don't need any pictures. Good.
Okay. This is where you want it.
Yeah, that's where we want it. That's where your lumen
I
was
don't know.
closed. 12 atmosphere, and then remember the Wolverine, you can go 14, 16 without any problem, without worrying about rupture. The old cutting balloons we had to use to rupture at 10, 12. Now 16, actually people in Italy, they go 20, 22. Remember Cope's trial, average inflation pressure was 22.
If we are only doing LAD, then
Yeah.
why don't you go all the way? Okay, let's take a picture and see.
Okay,
Since we
now
never
we are
did one.
just 1 second. Little nitro, little Varap ml nitro. Let's get a nitro first. 1 second. Yeah. Okay. This is the third picture we are taking in this case. So total, so far we have done 12 cc's of dye. Yeah. I think looks very good. Let's take this out. We put one stent.
Huh?
Yeah.
Distal?
Yeah. One
But
stent.
what's the length?
38. You want to get 2.5 38 and then dilate differentially?
Hmm.
Yeah. Right?
Yeah.
Yeah. 2.5 38.
So you see that distal septal from there all the way.
Yeah. Right.
38.
Good.
I don't know. It will be.
While we are getting the
40.
balloon ready, let me just come back. You should go to the slide presentation. So stent ready. Yeah.
What synergy?
Go to our slide. Yeah. So this basically was, we always go with appropriate two vessel, appropriate in this case, because of ischemia and LED involvement. And then few things I wanted to present about this RotaCut approach which we have. There are three, besides having non-randomized data showing that RotaCut gives you better lumen compared to Rota alone or cutting balloon alone, we actually have three randomized data. One is the prepare calcium combo, and which was basically was the cutting balloon followed by stenting, a rotablation, followed by cutting balloon, and then Orsiro stent. And then what they did is the primary endpoint being angiographic acute luminal gain and stent expansion and follow-up, clinical follow-up. And they say to control group was the from prepare calcium. Remember, prepare calcium was the trial of modified balloon and rotational atherectomy. Rotational atherectomy plus PTCA and modified balloon was, whether scoring balloon or use the cutting balloon. So what they found basically in this combo, by using this RotaCut approach, they have a higher acute luminal gain compared to other two historical control. They're not a true randomized historical control. And the stent expansion on the OCT was much better with the RotaCut approach, 7.1 versus 6.1 and 6.2. The other endpoints were not different. Strategy success was definitely better with the Rota and cutting balloon. And then the target vessel failure at 9 months was identical, no difference. So yes, acute luminal gain was better. The expansion was better, but did not translate into a lower TVF in this study. Second study is ours, RotaCut. We have 60 patients, rotational atherectomy followed by cutting balloon versus rotational atherectomy with high pressure balloon and versus cutting balloon, rotablation with cutting balloon. And basically we found the RA with cutting balloon, a RotaCut resulted in a similar MSA compared to Rota with non-compliant balloon angioplasty. So no difference as you can see here. And of course, we don't have the follow-up, but there was no complication except one in each group had a CKMB elevation. So extremely 60 cases. We did 45 here, 15 for St. Francis, and we have zero major complication on this trial. Then the latest one just presented in Europe PCR called prediction nears IVUS. This is the cutting balloon versus conventional balloon, and they have the whole technique of the balloon. Downside by 0.25, gradually go up, frequency of inflation, you do a repeat inflation 2-3 times and post dilate. And basically what they basically found was that by this cutting balloon, this technique of slow inflation and multiple dilatation, cutting balloon gave you better MSA compared to conventional balloon. And this is before the stenting. And overall MSA based on the IVUS was much higher with a cutting balloon group compared to conventional group, 6.1 versus 5.2. But again, no difference in restenosis, but clearly, rather, it looked like cutting balloon numerically had a higher restenosis compared to conventional group. There's no other complication in this study,
covering the
and
diag.
basically also we found
Right.
that cutting balloon basically work if your calcium arc was more than 180. If it was less than 180, there was no difference in stent expansion or MSA,
Okay, some diag.
only in the calcific arc, and that actually was shown by the Cope's trial also. So these are the data we have with the RotaCut
Some diag,
approach,
right.
and so. Okay, go back
We are
to the
going
fluoro
up
now.
No, we're going to go up with
Yeah.
the stent.
Yeah.
We are not covering the diag.
Yeah,
Okay.
no, we're not covering the diag. That's the whole purpose.
Wait, some dye now,
Yeah.
some more. Just confirm.
There's 1
that.
cc of dye here.
Yeah,
Good, very good.
Okay, go. Yeah.
Yeah. Get a 3O balloon ready, which we had. We have it.
Done.
Yeah.
Go up again.
So basically go with the 2 inflation, how much you are going. You can go to 16 atmosphere.
No, distally we don't know. SS is 2.5.
This is 2.5 balloon.
The stent is probably in the lesion, distal.
Okay.
There's a few millimeter lesion there. My goal was to stay away from that septal, but the stent is distal to that now. Okay, ready?
Yeah. No, nitro. Give
Okay.
nitro
no,
first.
No, nitro. Let's
Yeah.
post dilate.
Okay, then post dilate. Don't give any dye. Yeah.
One final
Yeah.
picture.
So we are going to post
Oh, you
dilate.
know what? After post dilation, let's
Image.
do the IVUS again.
IVUS, yeah.
So we don't do anymore. So far we have done 3.
Yeah. Okay.
This is the same 3O balloon that we used before. We are going to use to post dilate
The proximal segment.
proximal segment. of
Actually,
the stent.
and once a balloon is there, you want to do a stent boost just to see your
No,
distal stent is nicely expanded.
No need.
I call it a stent boost is a poor man's IVUS. The old stent boost used to have very high radiation, but now the live stent boost actually does not have that much radiation which used to be in the past. So this is 3O, 12 atmosphere,
Okay. Go a little higher, no?
16.
Okay, down.
Okay, go a few millimeter in.
Yes.
That is the tightest.
IVUS is ready?
Yeah. Good.
Go up
Yeah.
here.
Low pressure here. 10, 12.
Actually, it may be 3O, right? Okay,
Okay,
Down.
14.
down.
Yeah, distal wants to do a little more. Distal, I would say go further and leave it here
Okay.
1 second. Yeah, do the stent boost 1 second. Stent boost live.
No,
Do the
why you
stent
need
boost.
stent boost?
No, I know that whether stent expanded or not. Just go on cine now.
No, this is
Just
not
go on
change
cine.
the cine.
I know, just go on cine.
No, we have to make there.
I
This
did,
we are
stent
on
boost
IVUS.
live.
No. Not on IVUS.
Anyway, okay. You're going 12 atmosphere here. It's a 3O balloon.
Okay, down. IVUS.
Okay.
Flushed it, everything good.
All right. Let's see it to believe it. Put the IVUS on the main screen now. We can tolerate it hemodynamically, so far so good.
And we are hydrating, right? EDP
Yeah.
was 10, so we are hydrating. Already got 300. Bring closer.
Good.
Yeah. I check
Okay, I'm at
image.
the distal edge.
IVUS
Risky.
onto the main screen.
Okay,
Yeah,
start
good.
to work. It's a distal native LED. It's coming.
Okay, not bad. Oh,
Yeah, it's a edgy. Good transition. Okay, expansion. Carson behind stent. This is edge. Yeah. Then prox LED.
The proximal LED has circular calcium but good lumen.
Yes, correct. So I will check again.
so distal
Okay.
edge.
Let's steady now.
Okay, yes.
Yeah, so this is a distal edge.
Yeah.
Like
Yeah.
1 second. You don't touch it. You don't touch it. Yeah, so distal edge, like a
Good.
smooth transition.
Very good.
Yeah, like a normal operation, no dissection.
Yeah.
Just a diffuse plaque after the
Yes,
stent.
yeah, we know
But
that,
edge
yeah.
looks okay.
But what I meant, distal edge, distally we have placed it at the right spot.
Yeah, correct. And now come back to the proximal edge. So long stent. Yeah,
At
I
the
see.
level of
So,
the diagonal.
yeah.
This
We
is a
wanted just-
diag from 10 o'clock. Here's
Yeah.
no stent, but
Yeah.
after that, the stent starts. So
Yes.
your stent is just after the diag.
That's what we wanted.
Yes,
Wow.
exactly.
So that's called as EYE, using EYE precision stenting.
Yep.
Yeah. So now it's a diffuse plaque, and MSA is actually the 4.2,
Oh,
Where?
like almost distal part, but it's a tapering vessel, and like more than 90% expansion of the distal reference. So actually, it's optimal. And like mid to proximal part is like you see the area is like 5 point something. This was our like a most severe calcified part. You see the aortic calcium behind, and our stent is like 5.0, but it's more than 5.
No, but do you want to go with the 3.25 and bigger?
Actually, this part, the EEL is, as I told you, this is a 3.5 vessel. If you want, we can do 3.5 post-dilatation.
What everybody feels, should we post dilate with a 3.5 based on the IVUS finding?
I think we have received a substantial lumen gain. I think given the fact that it's a very diffusely calcium, I think I would accept the result. This is in the distal, I think we are getting around 5.
Yeah.
no. Distal is not 5. Proximal is
4.3.
Yeah.
Yeah,
Distal is 4.3,
Yep. In the
which is
proximal-
okay. I mean, I think that's the vessel, it's the limitation of the vessel.
Yes.
Only thing is the proximal point.
Yep.
It is that vessel can be enlarged further. I mean, the stent is expanded, but can be expanded further.
I would leave
You
it
know,
alone
ah.
because one elderly lady, calcific, so many comorbidities, let's not get
Is there any
gung on
Karina,
looking at IVUS. Yeah.
can you show the diagonal ostium from the IVUS pullback of LED?
Sure. Exactly. So yeah, you see the from 10 o'clock, this big branch, that diagonal.
Ostium was good and the stent exactly at the distal to the diagonal.
Correct.
Just beyond the diagonal.
Yeah.
That's good.
So we take out the wire.
Yeah.
So we take one final picture, right?
Which is you can come back to the angio.
And we are just going to take one final picture.
Show angio.
Oh.
Go to, angio, yeah. I mean, diagonal is diagonal. Holding on.
Yes.
Lot of disease, holding on. And as we said, that of course the whole vessel,
EKG, you know that.
multiple disease there. The patient otherwise, even LAD, I mean, sure, there may be further down, we start doing the IVUS lesion there. But more importantly, diagonal remains good. Ostium remain good. It's kind of what we had before. And our purpose was to take care of the mid LAD after the diagonal by the RotaCut approach and high pressure balloon dilatation. We are able to achieve it. Good lumen. Yes, it can be a little better, but I think taken everything together, it will be okay to just stop here and, we call it DBC, don't be crazy, because it looks good. Let's take the opinion of the rest of the panelists and where should we do? We stop, go further, optimize further, or what?
Yeah. I think it looks quite good and it's time to stop.
Beautiful. Okay. All right. So I think we were able to achieve this in our timely fashion. And if you're okay, I will join you. You can start our the case discussions. We have 4 or 5 dedicated lectures on this subject. And I'll join you in about 3-4 minutes and we can start further discussion. And thank you very much.
Thank you.